I think we're going to end now. We'll do a little bit of a round robin. I'll ask each of you for if there's one point you want to communicate about MDS from everything we've discussed, what would that be? And maybe I'll start with Jamil.
I like to say that the disease is highly heterogeneous, that we shouldn't underappreciate that point, that I think even though we have available therapies, that we should all think about including patients on clinical trials. That's extremely important. It's about time that we get second-line treatments after, 12 years of no new therapies. So hopefully we'll have increase in accrual to clinical trials in MDS.
Super. Ellen?
I mean, I would like to add to that it's really important to look at the patient in front of you and to actually try and figure out and be able to communicate to that patient what their disease is and what the prognosis is, and to choose a therapy for them. But one of the things that's so disappointing about clinical trials is that we really are underrepresented in that over 75 group. I think that sometimes is a bias against enrolling those patients who are a little bit more frail and a little bit older on clinical trial. And I would really hope that people start looking at those patients that are a little bit more frail and a little bit older and try and include them on clinical trials, that we really need to make a very strong effort to bring these older patients who are a little bit more frail onto clinical trial with the complete realization by the year 2030, 12% of the population is going to be over the age of 80. And these are going to be people that we will be, hopefully, with our 25-year-old muscles, be treating, and that we need to have good data in order to treat these really older patients.
Nicely stated. Rami?
So I think I'm hoping that we're on the verge of really introducing several new drugs for patients with MDS and hopefully being able to improve the outcome for our patients. Again, none of them could be a cure, but they are definitely going to be improvement for the patients, whether it's decreasing transfusion dependency, or improving outcome in bad disease. I think for my colleagues in practice, in oncology practice, I would say it's always helpful to go through 3 steps. First, verify your diagnosis. Make sure you have the right diagnosis, because there is so many things that can look like MDS. Get all the testing that needed. I think mutational testing is helpful. Risk stratify the patients and tailor treatment accordingly. Think of a transplant for patients that have high risk feature, because it remains the only curative option still for those patients if they are candidate. And then stepwise treatment for lower risk is reasonable. Anytime we restore hematopoiesis for patients, we probably are helping them, whether in quality of life or survival. And again, hopefully in a year or 2, we'll have 3 or 4 drugs approved for our patients.
We keep hoping. That would be great. Well, I have to say that if I had MDS, I would want any one of you to be my doctor. So thank you for joining me today. On behalf of our panel, we hope you found this peer exchange to be useful and informative.